Okay, everyone, thank you for waiting. Welcome to the Medentors Society, and specifically, welcome to session 5, where we're going to be going into life as an NHS junior doctor. And today, we're joined by a very special guest who we're going to be introducing very, very soon. So, it's not going to be me doing the speaking this time. And we're going to be talking into what life is like as a junior doctor, what sort of things to expect. We're going to be getting very realistic with what we can expect with regards to things like strikes, regards to pay and prioritization, as well as what a day in the life is like and what rotations are, and also a bit about medical school and how you can make the most out of that. So that's sort of the itinerary for today. Um, so for those of you guys who are new and don't know about the Medentors Society, welcome to the Medentors Society. We are a group of UK medical dental students as well as healthcare professionals in medicine and dentistry who help you guys not only get into medicine and dentistry with support for the whole admissions process, but also an insight into the career with things like this. These sorts of webinars are going to be golden for when you guys reflect on your personal statements because it's going to give you insight into what to talk about, a realistic insight. And for a lot of people, it's very difficult to get work experience, which is why we've sort of set up this stratosphere and environment for you guys to get involved. And our recordings are also on YouTube. So I definitely recommend sharing these events with your friends and everyone to really get involved and understand what makes the best applicant. Okay. So we work with schools as well. So if you guys are interested in us doing visits, we'll work with loads of different organizations. So please do get us into contact with your head of years. And we also have a branch called our Academy, which helps you guys with your A levels and succeeding in your grades, achieving those A's and A stars. So that's another great opportunity I would definitely get involved in. Okay, cool. A bit about our reach and what we reached out to. So far, over the past few years, we have reached 3,000 plus students and helped them with the application. That's a really big number, and partnered with 20 plus schools and organizations. For those of you guys who are in our WhatsApp community, you'll have the opportunity to reach out to different people, our mentors, and ask for support and advice, which is a really good free resource I'd always signpost you guys to. And 95% of our students that do enroll within our courses do end up getting offers. So definitely do look into that as well. So what I'm going to do now is hand over to one of our society leads, Maria, who's going to be talking into what the Medentors Society specifically does for you guys. Okay?
Hi everyone, my name's Maria. I'm a year 13 applicant for medicine and I am the medical lead of the Medentors Society. So similar to what Mohammed said about what we do in the Medentors Society, it's all about giving people an insight into medicine, into a range of different fields, not just for medicine, but also for dentistry. We've had a trauma surgeon before, we've had a pediatric dentist, and I'm sure you will enjoy the experience today with Dr. Tesneem, who is a junior doctor. So in terms of other things we do, so we also run, we're looking to do competitions in the future, like essay competitions, and really trying to help people on the journey of applying to medicine. So it's not just about, what you can include in your personal statement, it's also you actually having your own insight and actually making you actually more motivated and more excited for a career in medicine or dentistry. So I'm going to hand over to Dr. Tesneem now, who's going to be giving the presentation today.
Hello, everybody. Let me just share my screen. Can everyone see that? Okay.
Yes.
So, hello, everybody. My name is Tesneem. I am a junior doctor based at the West Midlands North Deanery. I am currently an F1 and I have just started my third rotation, which means I will be an F2 very, very soon. My pathway to medicine. So if you guys have not picked up from the accent, I am not from England. I am from Northern Ireland. I came from a small school. I never really thought of medicine as a career. I was always interested in healthcare, but I thought more of pharmacy. To be honest, I didn't think I would get into medicine because it seemed very complicated. My parents aren't doctors, so my first experience with a doctor was my elder sister. She got into King's College in London, and she was my role model. So I saw how she enjoyed her first and second year of medical school, and it really motivated me. I then applied for a range of medical schools in England, not hearing of any of the city names, and I just picked one based on the program. So I went to Hull York Medical School. Hull York Medical School really emphasised the importance of PBL in their learning. And I'm somebody that loves learning from other people. Um, so I picked that medical school, and it was one of the best decisions I made. I also ended up going to medical school with my brother. He got in on results day, which I can speak about a little bit later if anybody's interested in what happens if you don't get an offer. I've had quite a few experiences with that. Um, Let me think if there's anything else I'd like to say of medical school at the minute. It was some of the best years of my life. It is the truth when people say that university is some of the best years. I think you're growing, you're learning about subjects that make you really passionate. You're also independent if you live out. Even if you don't live out, it teaches you a lot of independence, and you can make some of the bestest friends, which is what happened in my case. Okay, so let's talk a little bit about the NHS training pathway because this can be a little bit confusing. So, if you are all in UK medical schools, which I assume you are, you will apply in September, October of your year five, your final year. You will apply on a platform called Oriel. Oriel is a platform you will always use. So even after F2 and you're applying for specialty training, that is the platform. So if you've ever heard of it, somebody speak of Oriel, it's basically the application. It's basically the UCAS of post medical school. So you will do your FY1. At the end of your FY1, you will have something called an ARCP, which is an examination to check for your competencies. So the things that you would have to get signed off in medical schools, like CBDs, people observing you in observations like bloods and cannulas. A foundation panel will review if you're competent or not, if there have been any concerns. And if not, you will pass and you will get your full license. So at the minute, I'm a provisional license, which is very good because it makes you a little bit, it makes you feel like you're quite supported. So, for example, you always have a senior. If something goes wrong, it's less likely to be your because there's a lot of people that are higher from you. And it just makes you feel like you're supported during that year. During FY2 in the September, October period, will then apply for your specialty trainings. So a lot of people will take F3, gap years, sometimes they'll locum, they'll also do some research and teaching opportunities where they can then enhance their applications to apply. Some people apply for CST, which is core surgical training, or things like IMT, which is any of your medical jobs. So gastro, cardiology will have to go through IMT. A lot of people will do research fellows, so that's where you can spend a year doing research and build up your research portfolio if research is something that you're interested in, and also teaching fellows, which a lot of you might have seen in medical schools. They are, I think, the main pathways that people will go into after F2. Then, if you get into a specialty training, there are programs called run-through programs, and then there are non-run-through programs. A run-through program, so for example, GP or PEDS, means you get in and then you don't have to reapply. You might have to do exams and things for competencies, but you won't have to do another application. A non-run-through program, so for example, a medical, so IMT or surgery, you will have to reapply. Um, I hope that makes sense. And if you have any questions, we'll leave some time for the end. Okay, so medical school. It is usually 5 to 6 years. If somebody tells you that it's 6 years, it's usually because their medical school will encourage an intercalation year. An intercalation year is basically 1 year out, usually between the third to fourth year or the fourth to fifth year, where you can do another degree. And because you already have a strong foundation of your medical knowledge, it will only take you one extra year to complete that degree. So the most common ones are clinical anatomy, which I think would be very beneficial. People can do women's medicine, so like gynecology if you're interested in that, or you could also do a master's and it will only take you a year. The reason why people are more reluctant to do it now than they used to be is it used to enhance your portfolio in terms of applying for training. It would add more points. But now that I'm looking at applying for training, it might not enhance your points, but it definitely enhances your portfolio. So I think if I could go back, I probably would have done it or considered it just because you won't get another opportunity, an opportunity that's that well supported to do another degree or to build on your portfolio. My sister, for example, she did a master's. In her master's, she was able to publish 3 papers. That's quite difficult to do if you haven't done another degree, and it will take more time. Whereas she was allocated a year where she was able to spend a lot of time on data collection and writing up publications. So preclinical years are usually your first and second year in most medical schools. That's what it was for me. Preclinical basically means you're not going into hospitals as such, and you're focusing more on anatomy and physiology. So, what is anatomy and physiology? Anatomy is talking about the structures of our body, so the nerves, bones, skin structure, etc. And then physiology is how our body normally works. So, for example, how the circulation in our body works, how the brain works, how arteries and veins, etc., things like that. And then pathophysiology, which is something you will learn in clinical years, is how it can go wrong. So basically, diseases, pathologies, things like that. Okay. So that's mainly the anatomy and physiology is what you learn in your preclinical years. And then during your clinical placements is when you will be exposed to and you will also learn about pathophysiology. It's really nice because a lot of medical schools have a spiral curriculum. So if you ever see this when you're applying, um, certainly my med school did it and I really loved it. So a spiral curriculum basically means that they touch on certain topics all throughout your 5 years. And every single year that you do it, you have more knowledge of other body structures, of other systems. And slowly but surely, you're building on the knowledge that you already have. And by the time you get to fifth year, you've realized that your knowledge is solidified on a lot of systems and concepts in medicine, which is what happened for me. So during my preclinical years, I can't believe I'm even saying this because I used to be someone that didn't love to study, but I think when I picked medicine, I picked something I was passionate about. So if you're passionate about learning about the human body, if you're passionate about medicine, it you will enjoy learning. So I really enjoyed learning and I gave it my all in my preclinical years so that when it came to the final year exams, I was much more relaxed about it and I actually sometimes enjoyed the exams because I knew what I was doing. Um, and my foundation was very strong on these subjects. So, in terms of exams and OSCEs, exams are quite a big change from what they are in A levels because in A levels you're used to grades, so A star, A, B, C, D. In medical school, it is true, it is a pass or fail. Sometimes there's distinctions. Um, But I quite enjoyed that because I think sometimes when you're in A level, you're so wired to worry about grades. And in medical school, it changed my perspective because I thought I would love to be more of a competent doctor than think about what grade I got in a certain examination. Usually pass marks are around 60%, and the majority of the year will pass. People talk about a levels being the hardest exams of your life. Do I believe that is true? Yes. Um, I don't think medical school exams are as hard as A level exams are because in medical school exams, if you learn the concepts and you understand the concepts, you will score high. Sometimes with A levels, I think they can be a little bit more complicated and sneaky with questions. In medical school exams, they're not sneaky. It's difficult because it's single best answer in multiple choice questions, so all your answers will be correct. It's the one that's most appropriate. But what I found, anyways, is I didn't score as high on my GCSEs and A levels, but I scored the highest on my medical school examinations, and it was just because the content was more interesting. Um, and also if I learnt what my lectures were giving me and watching some YouTube videos, which I really enjoyed doing, then I was scoring and I was scoring comfortably. Um, so they are much easier. But I will say one thing, you do need to revise for your exams. There were people that don't revise and then hence unfortunately don't pass. So it's not something that you can come into and just guess. Let me change the slide. Okay, so I've spoken about the F1 and F2 program. What happens with applying and what's going on at the minute, because it is quite stressful, especially if you don't really understand the system, where people are talking about not getting enough jobs. So when you apply on Oriel, you will basically apply and rank all the deaneries in the UK. So you don't just rank the top 10, you have to rank all of them. I can't remember how it was. I think it was like 28 or so, or 14, I can't remember. But you rank all of them. So you'll even have to rank Northern Ireland, you'll have to rank Wales. It's just what's your top priority. So a lot of people will put London if they've got family or they just want to live in London. And then if they don't get London, they'll be moved down to whichever section has space, if that makes sense. But what they do, which is really good, is they'll release the ratios. So, for example, I'm in West Midlands North, which is the one that is the like you're guaranteed to get it if you apply, and no one really wants it. But I've started a life here, so that's the reason why I wanted it. But the ratio for West Midlands North is, I think, 2 to 1, so for or 1 to 2. Yeah. So I think about 200 applicants apply for my deanery, and there's 400 spaces. So the other 200 people will be people that didn't get their top choice that moved into that deanery. I don't know if that makes sense. I hope it does. What do the ranks depend on? So before they used to depend on your medical school grade. So for example, they would take an average of how you did over the 5 years or the last 3 years. And they would rank all their applicants, and then Oriel would kind of see who was top in all the medical schools and give them their top priority. The reason they changed it was we did a BMA vote, I think 2 years ago. It was the 2 years before I applied. And the reason was, which I do think is kind of fair, is that all medical school exams are quite different. They weren't UKMLA back in the day. So how someone ranked in one university and how someone ranked in the other university didn't really compare because the exams were different. So they decided to do it random to give everybody a choice. Obviously, I need to be transparent. There'll be a lot of people that didn't get their top choice and a lot of people that will have to move, sometimes a flight away, sometimes a 6 hour train ride away. And that can be incredibly difficult, especially when you're starting a new job. Um, so that's something that you need to factor in mind. Whether it changes by the time you guys become doctors, I'm not sure. But I think being familiar with what you're signing up for is very important. Um, so it's worth a thought. It also applies for other specialties. So, for example, my partner was applying for some specialties and he would get offers, but they would be quite far away. Um, but the difference between applying after FY2 for specialty programs, whereas when you're applying for the foundation program in your med school, is the one when you're in applying for the foundation program is random. The one where you apply after FY2 is based on your portfolio. So portfolio are things like what teaching have you done? What research have you done? What things or activities or extracurricular academic things have you done to enhance your portfolio? So you can work on getting the location that you want, if that makes sense. Okay, so rotations across specialties. When you've applied for your location, so after I applied for West Midlands North, then there's a second run of applications. That second run is basically applying what specialties and what hospital you want in that deanery. So for example, I'm West Midlands North. So the areas I could have gotten in that region are things like Stoke, Walsall, Wolverhampton, um, I can't remember the other ones, but they were the main ones. Dudley, Russell's Hall, all them, the ones in that region. You would then have to rank which specialties. So what is difficult is I would see the hospital that I wanted, but it didn't have the rotation. So you kind of have to gauge, Do you want the hospital? Do you want the rotations? You kind of have to weigh up your options. The best way to do that is by asking other people. I got the hospital I wanted, but the last line of rotations that I wanted, if that makes sense. So I think I ranked, there was about 40 different specialties for that one hospital, but I got the last line. So I'll speak on my experience in a few slides. Um, and yes, learning to manage patients independently. So the whole point of the foundation program is learning how to be a doctor, because the difference in what you learn in medical school and the foundation program are very different. Okay, so what is FY1? So like I mentioned, it's the first year where you're working as a doctor. You're essentially the bottom of the food chain. You're supervised but responsible for patient care. So what I mean by that is, especially on your on-call shifts and your night shifts, as an FY1, you're the doctor that sees the patient the most, even on normal ward days. You're the one that stays on the ward the most. You're the one that will hear all the concerns of the patient. You're the one that will check the test results, scan results. You are essentially the person who's most knowledgeable about that patient, which is a great thing because it then makes you learn loads. Um, it can also be quite stressful because if you get a scan report or a blood test report that's abnormal and you're the first to see it, you have a little rush of panic. But you always have supervisors. So whether that's your FY2 or your reg, sometimes even the consultant, you will always be able to escalate to someone as an FY1, even on your night shifts and your on-call shifts. It is a huge learning curve. A lot of people told me that, but I didn't realize it until I started. I think it's something where you're just thrown into the water and you're forced to swim. Um, but that's also good because I think there's a difference between somebody telling you how to do something and you just realizing it for yourself. Despite it being a huge learning curve, it is a safe learning curve majority of the time. So I don't want anyone to think that you're just basically sent out and you're not really sure what to do. You always have support. You always have a senior as an F1, always. Um, and I think there is a difference between somebody telling you how to do something and you doing it for yourself. So for example, um, if I was to tell you how to swim and I was to show you videos and explain it in depth and you were to swim on yourself, you wouldn't really learn and have that muscle memory like you swam on your own, which is something that happened a lot. So even with things like A to E examinations, which we'll talk about in a bit, until you practice them, you won't be as confident and familiar with which elements are which, if that makes sense. Okay, so this is the typical hospital team. So you have the consultants, you have your registrar, which is the grade above the SHO. SHO is FY2. So SHO/FY2 and then FY1. You'll also have some nurses. Nurses can be great, especially on your ward days or night shifts, because they also see the patient. They see the patient more than you. So they'll be great to ask. For example, sometimes I want to check if my patient's eating or not. Sometimes my patient has complained of some pain, so I can be able to ask them where exactly, when did they start complaining about this, or falls, which is what I saw a lot on my elderly medicine rotation. They had witnessed the falls a lot of the time, so they were really great for that. Pharmacists have saved me during my FY1. Um, you do the prescribing exam, but I think pharmacists are great in terms of they always check over. So some of the medications that you've prescribed, they can also educate you on polypharmacy. Polypharmacy is basically when a patient is being prescribed a lot of medications and some of them can interact with other ones. Pharmacists have been great when I've had to prescribe things that I weren't really familiar with. And also allied health professionals, so things like occupational therapists, physiotherapists, which are really important because sometimes, especially on the elderly care rotation, I had to make sure that my patients were mobile and they were back to a good position where they could go home before I would send them home. Or dietitians, so if the patient's not eating or having some swallowing difficulties, they were also great as well. So that's when we talk about working in a multidisciplinary team, it helps a lot. So if you've ever, I don't know if any of you guys have done work experience. If not, please try to get some where you're part of a board round or a ward round, and you will notice that there will be some nurses, some pharmacists. In mine, there was a physiotherapist, a nurse in charge, and then the FY1 and FY2 doctors, as well as registrars and consultants. And everyone was giving their input, things that they'd heard about the patient or were concerned about the patient. And you're basically getting the best of everybody's knowledge put together, and it then allows us to work together for that common goal, which is the care of the patient. So a typical day on the ward. So as an FY1, you are usually there the earliest. So the registrars in F2 sometimes start at 9. So if it's a medicine rotation that you're on, so something like geriatrics, cardio, resp, you will start at 8:39. And if you're on surgery, it always starts earlier. So we will arrive early at 8:30, check the bloods. We will also prep the notes. We will we will do a board round usually, which is what happens for a lot of the medicine rotations, where what I mentioned, everyone comes together and gives inputs for the patient. And we would complete jobs from ward rounds. So jobs are things like requesting scans, phoning other departments to liaise with them, checking bloods. Um, and we will review patients on the ward round, so doing a simple examination, and asking them questions, asking them how they are, updating them with their plan. We will also write discharge summaries, which is basically a documentation for the patient and also other health professionals like GPs to explain why the patient was admitted to hospital, what we did, and if there's anything further that needs to be done. And then handover. So there will also always be a doctor on call or a night doctor that if there are things that need to be done during the evening or didn't get done during the day, you will be able to hand them over. Um, and the main point of handover is usually so that the day doctors don't go home late. Okay, so I've explained the ward round. So yeah, this is an important point as well. There's a lot of times I will come on the ward and it'll be doctor, doctor, something happened overnight. Someone's scan didn't get done, someone was too ill to have an intervention or procedure, and then we'll be able to talk about it in ward round and then see what we should do during the day, what tasks we can do to ensure they can get the scans or whatever needs to be done. So common FY1 jobs, you will do blood tests, cannulas, so the skills that are required, requesting scans, which like I said is quite common, prescribing medications and writing the discharge summaries. Okay, what is a bleep or a pager? Pager, I think, is more American, and bleep is what we use in the UK. So this is what you get when you're on call. They always look a little bit different. It's a little device this size, probably the size of your iPhone, maybe smaller. And you carry it around when you're on call. So on call during the day or on call at night. And the wards that you're looking after will bleep you. So for example, when I was on my last rotation, a medical rotation, I was in charge of 4 wards. When I was on my surgical rotation, I was also in charge of 4 wards. So they would bleep me during the night. Main things they would bleep me for were sometimes bloods or a cannula if they weren't able to do it. An unwell patient, prescribing some fluids or some medication, updating some family members who hadn't been there during the day. What the bleep teaches you is how to prioritize your tasks. So sometimes I've been dealing with an emergency and I will get bleeped for something like prescribing fluids or taking bloods, and I'll have to answer the bleep and say, "Hello, I'm dealing with something urgent at the minute. I'll be there as soon as I can." Sometimes there are other health professionals that can support you. So AMPs, so some medical practitioners, or sometimes your FY2 or registrar will also be able to help you as well. I would say on-call shifts and night shifts are when you feel the most like a doctor, because even though you've got people to escalate to, definitely, you're dealing with the more acute emergencies yourself, and you only really escalate when you're not sure. You do escalate a lot, I'm not denying that, and that's something that's great because you always feel like you have a senior. But as the months went on, I felt like I would be there first, assess, make a management plan in my head, and then if I was a little bit unsure, calling my registrar and sometimes confirming or tweaking my plan a little bit. So it's when you feel the most like a doctor. Oh, okay. So this is what I said about the on-call shift. So you're covering multiple wards, usually four. You respond to the emergency. So if someone's vomiting, um, if someone's feeling unwell, if there's a headache, things like that. You review deteriorating patients. Okay, one important thing to say is there are things that are called a met call. I don't know if anyone's heard of that. That's basically a medical emergency. So if the patient is very unwell or is um, we have parameters where we check when patients are scoring. If they're scoring high on the parameters, which basically means they're deteriorating, any healthcare professional, including me, including nurses, including anybody, can put out something called a met call. That is when there's a team of doctors, a registrar, some FY2, sometimes FY1s, medical practitioners. They are there to deal with the medical emergencies. So there has been a time where I went, reviewed a patient and realized the patient was deteriorating really fast. I needed help. And we put out a met call. Usually it's 2222, or whatever it is in your hospital. And they will all rush in, all help you. There will never, ever, well, from what I've heard, be like, oh, why did you put that out? It is much better that you put it out rather than put it out a little bit later when things could have been done. They will rush in, someone will lead it, someone will take blood, someone will be on prescribing, someone will be on examining the patient, and you're just very supported. So I don't want everyone to think that when I'm on call and I'm on a night shift and someone's deteriorating really quickly, I'm just there on my own. Okay, so common emergencies FI1C, so sepsis, basically an infection of the entire body. Some chest pain, hypoxia, so that's when you've got reduced oxygen delivering to your organs, specifically the brain. Delirium, which is an acute onset of confusion, and low blood pressure. So we would review the patient and then give them any medications or things that can help. A lot of the time, sometimes, not a lot of the time to be honest, but sometimes I've noticed, especially on the elderly wards, I'll get bleeped for a low blood pressure or a high heart rate. And when they did it again or repeated it, it was actually normal. So it might have just been that the probe wasn't on correctly, or just a bit of a malfunction. So it's always good to ask them to repeat whatever observations they've done again. So this is the A to E assessment that I mentioned. This might not make a lot of sense to everybody at the minute, but what I wanted to speak about is this is the one thing that they grill to you in medicine, but it is great because it teaches you how to assess anybody, any patient that's unwell, how to assess and give interventions, in order of importance, which is great. So I've used this a lot in my day-to-day life as a doctor. So some of the challenges of being an FY1, it is a very heavy workload depending on what rotations you're on. So like I mentioned earlier, I didn't get the line that I wanted. So for my FY1, I had one surgical job and two medical jobs. Usually the medical jobs are the most intense as an FY1. The rotations that are least intense are things like pediatrics, radiology, psychiatry. Because a lot of them will be supernumerary. Supernumerary is 9 to 5, so they won't have any on-call shifts or any night shifts. Whereas all my rotations have had on-call shifts, night shifts, twilight shifts, whatever shifts you can imagine, I've had them all. So it has been a very heavy workload, especially one after the other. And they are long shifts. So, for example, when you're on call, you're not usually on call for one day. You'll be on call for 4 days if you're during the week, and then 3 days if you're on during the weekend. But you always do get rest days, so a rest day before and a rest day after, sometimes even more. So yes, the responsibility for patients that can be quite daunting and nerve-wracking. Is you're responsible for patients' lives, so you can't switch off or um you have to, especially things like sleep and eating and looking after yourself, you have to make sure that you're at your best so that you can give the best to your patients. Learning hospital systems, that's probably one of the hardest things of the job. Every hospital will be different, so how to request scans and where the blood equipment is, where this department is, where you can get lunch, where the doctor's office is, all these things can take you quite a while to learn, but when you do, it can make your job a lot easier. Sometimes that's the hardest part of the job. Okay, so imposter syndrome. So for a lot of you who are applying for medical school or that are in medical school, you will be very familiar with imposter syndrome. So this is when you feel underprepared, you're comparing amongst people and your colleagues, you don't feel good enough, and you just feel scared. So imposter syndrome can actually stop a lot of people from applying for medicine, which it definitely shouldn't. Um, for me, this was something I definitely experienced before applying and even during medical school. It does get better, especially the more you practice something. So, for example, um, I felt it a lot in the start of first year. I felt very out of my depth. At points, even considered dropping out, which is completely normal. Um, and then the more I put time into my work and revision, the more I realized I was really enjoying what I was doing. And when I was seeing the results of my examinations, it was reflecting the hard work I put in. So the imposter syndrome went away for quite a while. So I think it's something that is inevitable and you will experience it at different times of your career. But the more practice you have, um, the more you'll be able to manage on those emotions. Sometimes I think imposter syndrome is good because it makes you continuously learn, and you don't want to be overconfident as a doctor because medicine is something that you're always going to be learning. There's always something to know. There's always new research that's coming up. You can always stay updated. If you're somebody that wants to go into something where you need to know everything about everything, this career isn't for you. But if you are someone that is willing to learn, and is enthusiastic about learning, this is definitely your career. I remember in first year, on my very first meeting with my supervisor, he said, you need to accept that you're never going to know everything in this profession. And I think it's very true. The quicker you accept that, the happier and more confident you will feel. So, learning from mistakes, this is a great one. So, medicine requires reflection, and I think it requires reflection from the day that you consider applying. There will be a lot of things that you will make mistakes on, and a lot of reflections and things you thought, oh, what can I do better next time? That is great because it's continuously learning to improve, and it's something that I've also been able to apply at other parts of my life as well. Escalating concerns early, that's something that I've learned a lot. I think when you're just starting, you want to be confident and you don't want to annoy anybody, but actually that's when you're the most safe. And patient safety always comes first. It is much better to say, do you know what, I don't know, than to do something that you're not sure of. FY1 salary. Okay, so I think this is a really important one because I wasn't really sure on what the salary was. So your base salary is around 32,000. Majority of the FI1 pay does come from nights and weekends. So if you are someone that are supernumerary, I am going to give you some ballparks of what people are earning. So if you're a supernumerary, you're earning as in take home pay, so after taxes and national insurance and student finance, things like that, you're taking home around 2.1, 2.2K if you're supernumerary. If you're on an on-call rota, it's usually 3K 2.9, 2.8, something like that. That's your take-home pay. I thought that would be quite enlightening because I was too scared to ask that before I applied. But it's something that's really important because we all need income at the end of the day. Um, so that's how much it'll be. So anywhere between 2K to about 3.3K. Okay. So take home pay. So there's the income tax, national insurance, student loan, and pension. So there's something called an NHS pension scheme. Around, I think, 300, 400 of my salary goes to my NHS pension. You can opt out of the pension. It's completely your choice. But it's something that you'd have to do a lot of research on because a lot of people say that the NHS pension is one of the best pension schemes. And it's something that you don't really need to worry about. They take it out of your account every month, and it's there when you need it. Doctor strikes. So there's actually a strike as we speak. I am currently striking. So the strike originally happened because of the pay disputes. I'm sure you're all familiar, so I won't bore you with this. But another reason that we're striking, and probably the main reason, is there are not enough training posts. So a lot of FY2s are becoming unemployed, or struggling to find jobs. So that is the main reason we're striking for at the minute. They're always organised by the BMA. You're not penalised if you strike. You don't even have to tell your organisation that you're striking. And the majority of doctors, I don't know anyone that isn't, strike. So whatever sometimes you've got night shifts, you're on call, your normal ward day, your supernumerary, whatever it is, you're all allowed to strike. So we spoke a little bit about the competition for training posts. So some specialties have become extremely competitive, and some doctors are taking F3 years. What was passed a couple of months ago was the UK grad prioritisation scheme. So what used to happen was if you graduated from the UK or you were a UK citizen and you were international, we were all competing for the same posts. But what has now happened is whoever has graduated from the UK, they will be placed at top priority, which has made a lot of difference to the competition ratios. But we'll mainly see that next year for the first time. They've done it this year for a couple of them, if it was in just before applying for them, but we'll mainly see the effects next year. So this is the visual training pathway timeline I thought to put in, if you wanted to look at the slides after. So it's usually 10 to 15 years of total training time. That's if you're full-time. If you're part-time, it might take you a little bit longer. Okay, so we've spoken a little bit about life during medical school. Medical school will help you set a big foundation into the knowledge that you need for a doctor, but it might not help as such with practical things. So, for example, requesting scans or bloods or practicing on-call shifts, but they are things that you can pick up on very quickly. The knowledge that you gain in med school will always help you. That's something I've realized definitely. So please put your all into medical school. You can revise a lot and still have a great work-life balance, because you are more in charge of your own time. You have a lot of time off. So do not think of revising content to pass exams. Think of it as this is going to help me in my career as a doctor. Balancing medical school. This was something I developed very early on in med school. It was quite stressful at the time because I remember everybody was having a lot of fun and was very carefree. And I was still having a lot of fun, but I really wanted to manage my time and learn how to organize and have a good work-life balance from the beginning. So what I saw in a lot of my colleagues was it would come to the end of the year, especially in first year, and a lot of people are panicking, whereas I'd panicked at the start, developed my study habits, developed my work-life balance. So when it came to the end, I was chilling. I'm not saying this to be humble, I'm just saying it. There are a lot of geniuses in medical school. I am not a genius by any means. but I work hard, and that's all you need for medicine. You don't need to be a genius. You just need to work hard and be passionate. I don't think I ever revised in medical school more than 3 or 4 hours a day, but I was someone that was always a little and often rather than cramming. So before my exam, people would be like, "Oh my goodness, is she gonna pass?" Um, because I would only do 3, 4 hours, but people didn't realize that I'd done that from the start of the year. Um, so I think that method, if I could go back and do it again, I would do it exactly the same way I did it. I think that was great for my work-life balance. It also meant I was never panicking and stressing before exams, and anything I learned was more in my long-term memory than it was in my short. Um, and there were a lot of days I took off, sometimes weeks that I took off. This is all affordable in your medical school. Um, so these are some of the skills that medicine can teach you. So communication, teamwork, leadership, decision making, and resilience. You will have to manage a lot of tasks and a lot of workload, and that will teach you a lot, and especially in terms of organization and prioritizing. So let me think of the top 10 things that shock me as a doctor. So yes, hospitals are extremely busy. I haven't completely decided what career I want to do, but the more I work in a hospital, sometimes I think I don't know if hospital medicine is for me. But it can be really fun because it's very social. Especially if you go to a smaller hospital like mine. It's incredibly social. I've made some amazing friends. My siblings also work at the same hospital as me. So it's really fun. There is lots of paperwork. So some hospitals will be paper-based, some will be online. Mine is paper. So there's a lot of missing sheets sometimes and writing on paper. Teamwork is essential. You're working with people that you've never met before from completely different backgrounds, and that's really great for learning about communication and your people skills. And asking for help is normal. You will learn very quickly, and you won't even realize the things that you've learned until one day you're teaching someone else and you think, well, there was a time I didn't know that either. So this is a myth versus reality. So doctors know everything. That is not true. Medicine is teamwork and constantly learning, even as a consultant. You will constantly be learning, constantly seeing different cases and building on your knowledge. And you'll also be liaising with different specialties. So, for example, if there is a surgical patient and the surgeons have now seen a medical cause in the patient, they will then speak to the medical team and the medical team will come and review. Okay, so a chaotic night shifts. I've kind of spoken about this. They are manageable. Some night shifts will be a lot calmer than others. The more you do, the more comfortable you will feel with night shifts. Sometimes they can be really fun, and some of my best stories, and my most rewarding moments as a doctor have been from night shifts. We've spoken about the worst part about being a doctor. There's a lot of emotional stress and burnout. I don't know if anybody's familiar with this, but you can actually go part-time from the beginning of your FY1. You're not penalized, your application isn't penalized. You don't even have to give reasons as to why. You can just say that it's the lifestyle that you prefer. You can go 80% and you can go 60%. So if you go 80%, you will have one guaranteed day off every week that you can pick in majority of the trusts. And if you're on call for like 3 days or 4 days, they will also cut that day by one. So if you're on call for 4 days, I'll make you on call for 3 days, if that makes sense. Some of my best moments as a doctor were seeing patients recover. I did a geriatric medicine rotation, so because I was on it for 4 months, saw some patients that were in there for 2 months that eventually were able to be discharged, which is good. Helping someone through a difficult time, you will be very surprised at how simple things can go a long way for a patient. Sometimes when you're really busy, and a patient asks you for a glass of water and you quickly run to get them a glass of water, that can make far more difference to a patient than you can imagine. Would I choose medicine again? Medicine is challenging, but yes, I would choose it again. Um, a lot of a lot of you will be asking doctors and health professionals, is this a good idea if I went into it? Would you have considered it again? Sometimes when you're in something, which is normal, you can focus a lot on the negatives because that's just sometimes how we are as humans. But the grass isn't always greener on the other side. There are a lot of positives. A lot of the doctors are burnt out, and that's mainly a system failure. But medicine in itself is extremely rewarding. Um, Learning about the human body and having that knowledge is really lovely, as well as being able to help patients make some of the worst days of their life just a little bit better. Communicating with a family and being able to, something that's really helped me is seeing a family and thinking, if this was my family member, what would I like the doctor to do? How would I like them to speak to me? And it is a privilege to care for patients. Um, it is a huge responsibility, but it's very rewarding. So, the future of medicine, you've probably been hearing a lot of research on this, and this is something that might be a hot topic in interviews. Um, I'm not sure what's going to happen with AI and technology. A lot of people are saying that they will start to interpret, so like they'll do radiology things, so like interpreting X-rays and CT scans. I'm not sure, but one thing I can say is I don't think anything beats a human interaction. As humans, we love empathy. We love when someone listens to us, when someone's caring for us. Um, I don't think you will get that in a robot. So always the you might think being a great doctor is things like having amazing knowledge and being the best at what you do. And sometimes it is that, but it's also being caring and empathetic, listening to your patients, giving them the time, respecting them and respecting their choices. That's what makes a great doctor. I don't know if we have time for a patient story. Um, I will keep this for the question time, and if people don't have many questions or want to ask me about this, I don't mind sharing this. So these are some mistakes I've made as a new doctor. So spending too long on small tasks, that's definitely something. That happens a lot at the start. We're not very familiar, and then you pick up on it a little bit later. Being afraid to escalate early. I remember my first Met call that I put out. I was really hesitant to. I'm really glad I did, and everyone was really, really helpful. And trying to manage things alone. I think sometimes as doctors, we don't really want to ask for help, whereas asking for help is sometimes some of the best things that you can do to make sure that you're maintaining your sanity and your well-being. And sometimes it can really help you improve your knowledge and skills on some things. So tips for getting into medical school. So strong grades, yes, but not always guaranteed to get in. Um, UCAT preparation, so things like Medify. Um, Sometimes I think I've done a lot of research into UCAT and they say that 6 weeks is probably the best time. You'll reach a peak in your UCAT performance before it dips again. I did my UCAT about 2 weeks after my peak, so try and figure out when your peak will be and arrange it against there. Work experience, if anybody's wanting work experience that is in my deanery, let me know. Um, Volunteering is also really good, so things like working in a care home can show you a lot about patient care, especially if you go to a care home where there are patients that have dementia. You'll be able to communicate with people that might not be able to understand or retain what you're saying. And interview practice. I'm happy to give anybody interview practice or work with MedDen on this. I've actually been on the panel for interviews before, so I've been able to see it from both ends. Advice for future doctors. So stay curious, look after your well-being. That's the most important thing, and keep learning. One tip I would give for interviews is a lot of people will come with amazing answers, rehearsed answers, answers they've gotten from other people, which is great. Um, that's not the student that stands out. The student that stands out is smiley, lovely, talkative, confident. Can sometimes throw in a little bit of a joke here and there. They're the they're the candidates that are usually the best. Um, if anybody has any questions, I'm more than happy to answer anything. And here is a little barcode for a feedback form, which would be great for my portfolio. So I'd really appreciate if you could fill this out. And yeah, does anybody want to ask any questions? Just unmute yourself and feel free.
Thank Thank you so much, Dr. Tesneem, for the lovely presentation. Even myself as a medical student, I found that really useful just to get insight into what sort of things you're looking into. So now, guys, for those of you guys who are perhaps curious or have any questions, I've seen some really good questions going around on the chat. Now's the time to ask. So if you want to know anything about the career of medicine, what sort of things you can do, I would say now's the time to ask.
Hello.
Hello.
Can I do work experience with you? Because they say it's really useful for, applying.
Okay. I'll be able to send out my email. I don't mind sending out my email. I can send it to Mohammed afterwards if he wants to distribute it.
Okay.
If you know any senior doctors, I think they might be a little bit better. Or during my FY2 years, I'll probably be able to sign you off. I need to double check that, but I'm happy to give out my email, um, and see what we can do from there, if that makes sense. Is that okay?
Okay. Thank you.
There's a question on the chat that says you can't find in-person work experience, but you found paid hospital experience. I would never pay for in-person hospital work experience. I don't think really that there's any point for that. Definitely see, oh, online. Okay, online work experience. Yeah, again, online work experience shouldn't be paid. Even for example, this talk that we gave, this provides somewhat of an insight into what career of medicine dentistry shows. And also we've got loads of YouTube videos out there that are free and totally accessible. That also gives it insight into specific specialties like trauma surgery, pediatric dentistry, and the webinar I ran a couple weeks ago about life as a medical student. So there's lots of free things out there. You should never really be paying for work experience, whether it's online or in person. That makes sense. The
If
biggest tip I,
I
sorry, yeah, continue,
I
Dr.
was just going to say, just for work experience, this might not apply for everybody, but what I find most helpful is if you ask around. So even if it's like a neighbor or someone that you know that's a doctor, your local GP practice, also sometimes your school, they can also arrange it for you, like your career supervisor. I know that might not be applicable for everybody, but that's the ways that I was able to get mine.
Yeah, exactly. That's a really good tip. So what you guys want to do is first look at all the organic ways you can get your work experience. That means going to your local community, speaking to people, your parents if they've got any friends, neighbors, schools, community societies, whatever. Just try to reach email outreach as much as you can. If you email like 20, 30, 40 people, I guarantee at least one person will respond to you with some sort of positive insight or at least a direction. Um, Oftentimes I know lots of people when they do get work experience it's through a friend of a friend of a friend. Like it does take a lot of connection. So that's sort of how to get involved with that sort of thing. How do I know if I'm prepared for my personal statement and interview? Um, with that, I would definitely look into our guides, at Medentors. We've got the admissions guide, which has dropped, which has really good advice on this. But with this sort of thing, what I'd sort of say is for your personal statement, there's a few key competencies that you need to hit and talk about, such as work experience, a bit about your own skills like empathy, communication, leadership. If you've got a few examples that you can reflect on that, that's good enough. That's what I would say for that sort of thing.
Did they mention interview prep? Did you mention that?
Yeah, interview prep as well, if you have any
So
tips for that.
for interview prep, I would mainly say, I know this might sound a little bit silly, but definitely practicing in the mirror. You will be surprised at what things you can pick up on. So really important things are hand gestures, speaking with your hands, especially if you're someone that doesn't normally do this, practicing it is really good. Um, Also smiling, throwing in a little bit of a joke. A lot of people will come, and this is what I realized when I was doing the panel. A lot of people speak to me in a robotic way, and they will have a really great answer, but it will just be very rehearsed, very quick, very robotic. You want to be someone that's quite um chilled out a little bit. Also just feeling like I'm speaking to a human, smiling. You don't need to rehearse all your answers or learn them word by word. Um, you just need to be really friendly, passionate about what you're speaking about, have good experience. So it's not about learning everything word for word, it's about coming across